So welcome to this webinar. Thank you, Professor Yoko Kato, our mentor and main sponsor for these webinars. Thank you to Raja and to Dr. Liu for joining. Today, my co-moderator will not join, Professor Ishu Bishnoi, because he had an emergent surgery. Okay. So Professor Raja will help me in co-moderating this webinar. Today we have two eminent speakers, which I want to thank for joining, Professor Riccardo Ramina and Professor Ramesh Nair. I will introduce the first speaker. Professor Riccardo Ramina is professor and chairman of the neurosurgical department at the Neurological Institute of Curitiba in Brazil, which is also a postgraduate center of the World Federation of Neurosurgical Societies. He completed his medical residency in neurosurgery in Hanover with Professor Majid Sami, and he is board certified in neurosurgery in Germany and in Brazil. He published more than 200 papers, and he is author of several books and book chapters. He is editor-in-chief of the Brazilian Journal of Neurosurgery. He has been president of the Brazilian Neurosurgical Academy from 2017 and 2019, and his main academic interests are skull base, vascular neurosurgery, and oncology. And today he will talk about surgical treatment of large and giant vestibular schwannomas with special focus on residual recurrent tumors. So Professor Ramina, thank you very much for joining our webinar. And please, you can start your talk.
Thank you very much for this introduction. I'd like to thank you and thank you, Professor Yoko Kato, for this invitation, and Professor Raja. It's again a great pleasure for me to present our experience for the Asian CNS. I'd like to talk today about our experience, the large and giant vestibular schwannomas, surgical results. It's our institute in Curitiba, Brazil. There is nothing to disclose in this presentation. And then I would like to start a little bit on the history of vestibular schwannomas. At the beginning of the last century, the mortality was very, very high for these tumors. You see here, that's about 70–80%. And it's interesting to think that these people continues to operate that case at that time because they had a very high mortality. But fortunately, things change, and Harvey Cushing, at the beginning of the century, started to do bilateral suboccipital craniotomy and partial removal of the tumor. With this technique, with this strategy, he had about 20% mortality, and in 5 years, it increased for 56%. We should think that at that time, what they operate were very large tumors. They don't operate small tumors because there are no diagnostic possibility. He also introduced the electrocoagulation in 1926. But then his fellow, Walter Dandy, start to remove totally the tumor at the beginning also of the 20th last century, and with unilateral craniotomy. And he performed in 40 cases this approach and had a mortality of 10%, which was really very good at that time. And the cause of mortality, one of the causes was described by Atkinson, the injury of the ICA. And then they start to perform a diagnostic procedure, but the mortality was also very high. And at the beginning of the 50s, they don't want to inform the patient that they had a small tumor because the mortality was very high for this surgery. But then Olivier Krona from Sweden had the possibility to remove these tumors and preserve the facial nerve. And in Los Angeles, two different groups, the ANT groups headed by William House and Hitzelberger, they start to perform removal of these tumors with microscope. And at the same city, Kurtz and Rand did the red SIG approach and start to preserve even the 8 cranial nerve. In the 17th, we have the possibility of preserving more and more hearing. And the 80s, we understood much better the natural history of these tumors. And up the 80s, the total removal and zero mortality was the goal to be achieved, especially with the work of Majid Sami. But it's really interesting that nowadays we are back into the Cushing's time with subtotal removal, radiosurgery or radiotherapy, and there is no cure for the patient. And the best result is control of tumor growth. That's interesting. That's the history. We classify these tumors according to Sami's classification. We modify it. We have the T0 tumors that are the tumors intralabyrinthine tumors, T1 intracanalicular tumors, T2 endocypia angle, T3 those tumors reaching the brainstem, and then we have the large and the giant tumors, T4A, T4B, compressing the fourth ventricle. And we include this group of the tumors, the giant and the large residual recurrent tumors. That's our experience with almost 700 cases. Most of these cases have been operated with large tumors. And we have in this series, these large and giant residual recurrent tumors. I like to focus today, 36 cases. All these patients have been operated previously in other centers. What are the goals of treatment of the vestibular schwannomas? The small tumors, the goals of the treatment is radical resection and cure the patient, zero mortality, facial nerve preservation, and hearing preservation. But for the large tumors and the recurrent tumors, our goal is, again, removal of the tumor and cure the patient with no mortality, facial nerve preservation. Hearing preservation in this group is very problematic because most of these patients don't have hearing or the tumor is too large to preserve hearing. How about the surgical approach of this case? We used the red-SIG transmeatal approach, but we have all the possibility to use other translabyrinthine, middle fossa, mini petrous, and in some cases radiotherapy or radiosurgery. But we prefer for all these patients to use the red sigmoid approach because the red sigmoid approach has some advantage. It permits a wide exposure of the tumor, a perfect control of the posterior fossa structures, possibility of hearing preservation, facial nerve reconstruction, closure of the dura with no need to some fat tissue from the abdomen. And a short time is needed for this approach. And it's feasible for all tumor size. That's the advantage. Disadvantage is as intradural approach, but we neurosurgeon operate every day intradural. That's not really a disadvantage. Exposure of the ICA fundus, in our experience, it's also very good, this approach to expose the fundus of the internal auditory canal. And cerebral retraction with perfect anesthesiology, anesthesia, you don't need cerebral retraction. How about the position of the patient? We can use a different position of the patient for this red SIG approach. We prefer in our department to use the supine, the mastoid position. We can also use the same sitting position, the lateral position, park bench, and ventral position if the patient has also craniocervical junction tumors like in FHU. The semi-seated position is a very good position. I was trained in Hanover to use always the semi-seated position. When I went back to Brazil, I started to operate all my cases in semi-seated position because it has some advantage. We don't have so many CSF in blood in the surgical field. There is a reduction of the venous bleeding, and the cranial nerve dissection is easily. But we have some problems. We have the problem of the air embolism, the postoperative venous bleeding, pneumocephalus. The surgery, the position of the surgeon during surgery is not so comfortable. Monitoring of the patient is needed. Some patients could have some hemodynamic instability. Then we jump, we change for this supine position. In the last 30 years, we're using this position for all the patients because we have some advantage. We have a very low risk of air embolism, of postoperative venous bleeding, pneumocephalus. The position of the surgeon is very good for this for these lungs surgeries. And in our opinion, dissection of the tumor in the internal auditory canal is easily. We have some problems, but you should be used to this position because we have more CSF and blood in the surgical field. And dissection of the cranial nerves at the brainstem is a little bit difficult. How we position the patient is like that. You can see here the position of the patient with cushion under the shoulder. And then the incision we use in all the cases is a very small auricular incision, 6 centimeter, 4 centimeter from the out ear, from the external ear. We use navigation in this case to perform the craniotomy to avoid a lesion of the sigmoid sinus. All the cases are monitored for cranial nerves. And then we perform the red sig approach. We use the asterion as the parameter to perform the craniotomy and also neuronavigation. We prefer to use to perform a craniotomy, not a craniectomy, because in our opinion, it's much better to reconstruct the posterior fossa and has anatomical advantage and reduce the postoperative headaches. Facial nerve monitoring. We have many possibilities to monitor this facial nerve. Use usually direct electrical stimulation during surgery, continuous electromyography, and also facial motor evoked potential. Problems with preservation of the facial nerve is always we can identify the facial nerve in the internal auditory canal, but we should look for the arachnoid plane and then perform intracapsular debulking, identification at brainstem, and the facial nerve is at risk at the entrance of the internal auditory canal. Cystic and residual tumors are more difficult to remove these tumors and preserve the nerves. And how about hearing? In these large tumors, it's very difficult to preserve hearing. It's really an exception. But in smaller tumor, we can do it. We have tumor factors that affect the hearing preservation. At first, tumor size. Second, the quality of preoperative hearing. Grade of extension in the internal auditory canal. If they reach the fundus, it's much difficult to remove. Origin of the tumor from the superior vestibular nerve, it's easier to preserve hearing than from the inferior vestibular nerve. Direction of the tumor growth, vascularization of the tumor, and the consistency, cystic or solid. Cystic are a little bit more difficult to preserve hearing because of the nerves are very attached to the capsule. We have surgical factors for hearing preservation. First, we have to preserve the semicircular channels. We have to identify the cochlear nerve inside of the internal auditory canal. You can see here in this video. And then the arachnoid plane, direction of dissection is very important. We dissect from the brainstem to the fundus of the internal auditory canal. And intraoperative monitorization is also important. In these small tumors, we can preserve the cochlear nerve and also the facial nerve, in some cases also the vestibular nerves. I show you now a video of a large tumor that's a T4A. How do you do it? We open the cerebellomedullary cistern, expose the tumor. It's very important to dissect the arachnoid plane. And then you can see the fourth nerve. You can see here the caudocranial nerves, and then the trigeminal nerve at the brainstem. Then you open the internal auditory canal, at first with the cutting bore, and then with a small diamond bore. We used for many, many years a dural flap to cover the nerves after the end of the surgery. And then we dissect the tumor from the nerves. You can see that's in this position, this lateral position, this is supine position. And then after total removal, we checked with the endoscope to look for the open mastoid cells to avoid CSF fistula, and use the fiber glue and close the internal auditory canal. We should be careful because in some cases we can have a displacement, the dorsal displacement of the facial nerve, vestibular Schwannoma surgery. These are very rare, but we should be aware about that. You can see some papers in the literature that this position of the facial nerve, the dorsal position, is very rare. We have this case, you can see here, this is a large tumor compressing the fourth ventricle. And then we open the dura. And open the cerebellomedullary cistern, like in the previous case. Look for the arachnoid sheet. And then we drill the internal auditory canal. But you see that the nerve is located dorsally to the tumor. You can see that's the facial nerve. We have tumor in front of the facial nerve. Then remove the tumor step by step. That's the facial nerve, the dorsal portion of the tumor. We have tumor here, and that's the facial nerve. We think that in this case, probably the origin of the tumor is the intermediate nerve. And here, after radical removal, you can see here the facial nerve is preserved. We can stimulate the facial nerve at the brainstem. You can hear it. It's working very nicely. But if you are not aware about this position of the facial nerve, you can cut it at the beginning of the surgery. Some cases, you see this tumor, this is large tumor, and 6 months after the surgery, we have a grade 2 Hausen-Brackmann. That means it's possible to preserve the facial nerve even in such large tumors. It's another case, you can see here, it's also a large tumor. The patient 2 days after surgery, radical removal of this tumor. That's another case. That's the patient. The first day of surgery, consider is a palsy. That's a grade 4 palsy. But 2 months, 2 years after the surgery, she has a grade 2 facial nerve palsy, like this large tumor. Now, I'd like to talk a little bit about this group of the tumor, the large and giant residual recurrent tumors. We're seeing more and more such cases. We have published our experience in the book for SAMI and also in other papers, in other journals. And we took a look in the literature and saw that in the SAMI series, for 1,000 operated cases, he had 62 recurrent tumors. Most of these tumors were operated in other clinics. And in this series, 2 patients died after surgery. Look, 2 died of these recurrent tumors. Mario Sana from Italy reported 2002, 23 recurrent cases, 4 large lesions and 1 giant. But he was not able to preserve the facial nerve in any case. That means that's really a challenge to remove these tumors after previous surgery, and in some cases after previous surgery and reduced surgery. Our case, most of these patients are very young patients because young patients have larger tumor. All patients were deaf preoperatively, and 15 patients had facial nerve palsy. Some patients had also caudal nerve palsy. 16 patients with hydrocephalus, and 7 patients had previously radiotherapy or radiosurgery. And the question is, why these tumors became or remained large and giant? There was 2 reasons. The first one, the surgeon did not inform the patient that the resection was not total, and the patient think the tumor was resected, but the tumor was not resected. The second is the patient had some postoperative complication. The patient and the surgeon were afraid of a new surgery. Here you can see the video of such case. It's completely different because we don't have this arachnoid plane. We have some cystic and necrosis, you can see here. The nerves are attached to the scar tissue. It's completely different surgery because it's really difficult to dissect. It's hard. And if the patient was irradiated, it's much worse because everything is in the scar tissue. The tumor is hard, became hard. It's difficult to dissect nerves. It's here. That's a case. That's a large residual recurrent tumor. You see this tumor was operated once before. They did only a small resection of the posterior part of the tumor, and then you could remove totally the lesion. That's another case. You can see here the patient after radical removal of this recurrent tumor with the facial nerve preservation. And that's the surgery. 9 years after the surgery, you can see radical removal, the patient is cured, and the facial nerve is preserved. That's another case. You see after the first surgery performed in other country, you say they did actually a biopsy and told the patient the tumor was radical removal. And after first surgery, the patient had a facial palsy. And after our removal, total removal, and reconstruction of the facial nerve. That's a patient. He had a previous surgery. They actually perform a lesion of the brainstem, damage of the brainstem, and after radical removal at our clinic. That's another case, 2 previous surgery, and 10 years after radical removal in our hospital. And this patient had 3 previous surgery, and that's the remaining tumor. You can imagine 3 surgery, and that's the tumor. And after radical removal and reconstruction of the facial nerve. This 21-year-old female, before the surgery, you can see here, and after the first surgery, November 2008, it was an 8-hour procedure in 6 units of blood, and that's the remainder of the tumor. They did only a small biopsy. And they perform a second procedure. Again, a large procedure with no resection of the tumor. And she came to us, and in 4 hours, we removed completely the tumor with no transfusion. And that's the patient 3 months and 3 years after the surgery. But the worst scenario is when the patient was operated before and had radiotherapy and radiosurgery. I will show you some of this case. You see this patient, she was operated twice before, and they performed radiosurgery and radiotherapy. And this patient was after the surgery with complete facial nerve palsy, bulbar nerve palsy, and in a wheelchair. It's really terrible. It's a young patient with this condition. She came to us and removed completely the tumor, reconstructed the facial nerve, and she was able to walk again. That's another case you can see here. That's really a difficult case. It's a very young female patient with surgeries and this edema after radiosurgery. You see the residual tumor. She came to us in very bad condition because of the brainstem edema. And then we performed the first surgery, and the tumor was really difficult because of this brainstem edema after radiosurgery. You can see the surgery is difficult because everything is adherent to the nerves, to the vessel, to the brainstem. Then we had to stop this first approach because of the adhesion to the brainstem. And then we remove as much as possible of the tumor. That's after our surgery. And then 3 months after our first surgery, we performed the second stage of this surgery. The brainstem edema reduced, and then we are able to remove completely the tumor and preserve the facial nerve. It's very important to try to have a strategy. In my opinion, I have tried to remove at first surgery, probably I could not preserve the facial nerve. But you see here after this second surgery, the facial nerve is very thin, but it's working. That's the facial nerve. And then that's the trigeminal nerve. And that's the facial nerve. It's very thin, but it was possible to preserve this nerve and remove completely the tumor. Postoperative, the patient present a grade 4 Hausen-Brackmann facial palsy, but is recovering. That's after the second surgery here at Inc. on the total removal of the tumor. That's another case. Was also operated, irradiated at the worst case, and with hydrocephalus, and then total removal. And that's one case more with total removal. This patient had 4 previous surgery and radiosurgery. Was with tracheostomy and wheelchair when she arrived to us, and that's after total removal of the lesion. Our result in this 36 case, the tumor were giant in most of this case. Facial nerve was operatively in 21 case, and postoperative in 16 case preserved. That means we could preserve in 76% of this case the facial nerve. We had 3 cases of bulbar cranial nerves palsy, and total removal was possible in all cases. We had 2 CSF leaks and no mortality in these large tumors. A little bit about the facial nerve. What should you do if you preserve or not preserve the facial nerve? We study very often this the facial nerve and had a classification according to the radiological findings in this case. What do you do? If the facial nerve could be preserved, wait at least 12 months. But if you lost the facial nerve, then you perform the 7-7 anastomosis at brainstem. That's the best to do because you can achieve recovery of a grade 3 to 2 Hausen-Brackmann, or if it's not possible to find at the brainstem, the facial nerve. Then we use the 12th nerve to anastomose with the 7th nerve. You can see the results here. And that's a case of the 7th at the brainstem. You see postoperative, the patient recovered to grade 2, Hausen-Brackmann. And what we use for the hypoglossal facial anastomosis, we use the terminal lateral approach. We dissected the facial nerve into the mastoid region and turned down to the hypoglossal nerve and opened the perineural and put a terminal lateral. In this technique, we can preserve the tongue function. You can see here this case. But today and nowadays, you are seeing more and more partial resection of this vestibular schwannoma, with the ground to say to preserve the facial nerve. That's why I'm saying we are coming back to the Cushing's time, because microsurgery was so good developed to preserve facial nerve or remove completely this tumor. But in many centers, the people are trying to do partial resection and then radiotherapy. If you do partial resection, you know that a large portion of this tumor will recur and will cause problem. And then most centers are doing subtotal or near total resection and radiosurgery. We have radiosurgery in our department. It was the first gamma knife in Brazil. We have a perfection here. That means for us, it's very easy to preserve and to perform a radiosurgery. But even so, we are very critical to use gamma knife for vestibular schwannomas. Why? Because with gamma knife, we have no cure. Follow-up is needed for the rest of life of the patient. In our experience, we follow this patient 5 years after surgery. If after 5 years, the MRI is normal, the patient is cured. We don't need to follow this patient anymore. Surgery after gamma knife is more difficult. Large tumors with radiosurgery or radiotherapy have a poor control of growth. For a smaller tumor, the facial nerve and the hair preservation is very similar to neurosurgery, to microsurgery. With gamma knife radiosurgery, we can have some trigeminal deficits. We can have also hydrocephalus. We can have a vascular injury and aneurysm formation. And also malignant transformation is possible. It's rare, but it's possible. And if this occurs, we have 100% mortality. That's the series showing tumors larger submitted to radiosurgery. You see that the control, at long time control of these radiosurgery tumors are not good. It's going down, and probably this tumor will recur. And we should take in consideration that most of these patients are young patients. We have to follow this patient for many, many years, and the control is not that good. That's the tendency line of hearing preservation after radiosurgery. You see that some years the tendency is to lose totally the hearing. And that's a very interesting paper published from the University of Japan in Tokyo in 2021. They study older and younger patients. Older patients are those over 50 years old and younger below that age. The groups they study are similar, and the tumor control rate was quite good for the whole series, about 94.5% in 15 years. But you see that the younger the cohort had a much less tumor control than the older one. The facial and trigeminal nerve function preservation, we see that in the older cohort, 12% had facial nerve deficit, and at 32% patient at 9.6% trigeminal nerve deficit. In the young cohort, we had more facial nerve deficit, 20%, and also trigeminal nerve deficit, 14%. In this series, hearing preservation, you can see that is going down with time, the hearing after radiosurgery. And the other adverse event they published was a patient with vascular and inferocerebellar aneurysm in radiated field. They developed some aneurysm. 2 patients, 4.5% in younger group, developed malignant tumors. That means we should talk to the patient about this possibility. I look at literature to find malignant transformation after radiosurgery. You can find here, you can see we had many cases published. Probably the most service, most the clinic are not published their results. And I guess that more and more patients can develop these malignant tumors. Then finally, to conclude, what should you talk to the patient? What should the patient know about surgery and radiosurgery? We have one side of the coin with radiosurgery. That's a procedure done and on outpatient basis. That means the patient doesn't need to be hospitalized. There is no risk of bleeding or infection. The patient can return to the normal life after radiosurgery. High rate of tumor growth control, high rate of 7-8 function preservation, and the cost is variable according to the countries. And how about surgery? We need 4 to 5 days in the hospital, 1 day in the ICU. We have a risk of bleeding and infection. We have 2 weeks to return to the normal life in average. And the cost is also to discuss according to the service. That's one side of the coin. And how about the other side of the coin? Radiosurgery. There is no cure. We can have radio-induced malignant tumor. We can have actinic damage to the cranial nerves, vessel, and brainstem. Large tumors have poor tumor growth control. Facial nerve preservation similar to the surgery. Progressive hearing loss of radiosurgery. Surgical removal, if needed, is more difficult than after radiosurgery. And due to the danger of recurrence, there is need for control for the rest of life of the patient. And how about surgery? Cure in almost all patients. There is no secondary malignant tumor development. Preserve the hearing remains stable. If you could preserve the hearing, it remains stable, so not lose the hearing. And a high rate of cranial nerve preservation. That's what I'm saying to the patient every day with patient with acoustic Alumni, Vestibular Schwannoma. These are 2 sides of the coins. I think that's important to be very honest to the patient and to say what you can do for these benign tumors. Our conclusion, these tumors are large and giant residual tumors. The only treatment for this tumor is surgery. Complete resection is possible without major complication and no mortality. And preservation of the facial nerve remains a challenge, but it's possible even in these large recurrent tumors. I'd like to thank you again very much for this invitation, and I hope you can visit our department some days in Curitiba. Thank you very much.
Thank you, Professor Ramina, for this very nice presentation and actually very challenging cases that you showed us today. I think you gave a very strong message to us about the choice between surgery and radiosurgery. And I can open the discussion now. I think there are many topics to discuss. There is one question actually from the chat. The question is from Dr. Parek. He is asking, in cases of large tumors adherent to the brainstem and to the facial nerve, what is your strategy? Do you still go for radical tumor resection?
Yes, that's a good question. What should you do? If you remove the tumor and you have a very small part of the tumor with the facial nerve, I think with very good microsurgery technique, you can dissect it. Because the people are saying, oh, I'm letting tumor with the facial nerve, but what are you letting? A large piece of the tumor or a small piece of the tumor? A small piece of the tumor you can dissect. And then I'm going always to resect the tumor. Because if the patient has a recurrence after this, it's much difficult to dissect. And if you give radiosurgery, probably you have a problem with the facial nerve also. Then I tried it firsthand to resect this portion of the tumor.
I would like to add another part to this question. Does age influence your choice in those cases? I mean, do you think maybe for younger patients, it's better to be radical for the reasons you said? But if a patient is older patient, maybe leaving a small remnant is more acceptable?
Yes, actually, we are publishing a paper right now about the surgery in patients over 65 in our experience. And also with the conformity of the literature, we saw that this patient have a little bit more time to recover after surgery. A little more time means some days or some weeks more, but the results are the same. And then we perform also in this large, in this older patient, we try to remove radically the tumor. Because what we have as goal is to cure the patient. And we should also take in consideration that a patient, an older patient, we became older and older. And if the tumor recur, we have to operate again. He's much older than after the first surgery.
Thank you, Professor. Other questions from the audience?
Yes, I would like to ask Professor Ramesh Nair after you, please.
Thank you. Thanks, Ricardo. That was a brilliant talk. I think it's a very challenging scenario with the recurrent giant tumors, especially having had surgery and radiosurgery before. My question is about the position you use. You said supine position. Do you any situation where you would rather consider a sitting or lateral position, especially in obese patients, for example, or you always use supine, especially with the short neck patients? What is your view on it?
Yes, actually, I was trained to operate all these cases in same sitting position, like Sami does. But even in Hanover, we started at that time, many years ago, to decompress the nerves, the trigeminal nerve, facial nerve in this position. And then when I moved to Brazil, I started to use this position for small tumors. And even for obese patients and short neck patients, it's possible to put this position. It's very easy. It takes about 5 minutes to put the patient in this position. And the shoulder is not a problem, even in short neck patients. If you try, you should try at first with younger patient, with a long neck patient, but then you get accustomed to this position. It's not a problem.
Thank you. Yeah, thanks. One more, just say before Raja. Have you had any occasions where you encountered brain swelling intra-op? Because you often release a CSF prior to the procedure, but was there any occasion where you encountered, especially large tumors, the cerebellar swelling, and any strategy to deal with it?
Yes, only if the patient was operated before or irradiated before. That's the problem. At first surgery, usually in some vascular tumor, if you have a very vascularized tumor, you can have some brain edema. But I don't think it's a problem, because that's also an advantage of this position. And small tumors like T1, T2, even T3, you don't need a spatula to retract the cerebellum. You just open the cistern and the cerebellum falls down. You don't need any spatula. That means you don't need to manipulate the cerebellum and the brainstem.
Thank you.
Yes, thank you very much, Professor Amina. Just I would like to learn from you as there are so many young neurosurgeons watching this as a legend of great person like you. Just we want to learn what is the approach that you choose when you open, as soon as you open the dura, you see the tumor. What is the first thing you expose the IAC? Is that the first thing, or you just dissect and debulk the tumor, and also the direction of debulking, where you go superiorly, inferiorly, medially, or laterally? What is your, is there a defined system where you approach these tumors in your place?
Yes, that's a very, very interesting question, especially for the young people. What we do at first, when we open the dura, the first thing we do is to open the cerebellomedullary system. Then we relaxed the cerebellum and the surgical field. The second thing we do is to move the microscope to take a look in the tentorium to see the veins, to see where the petrosal vein is, to avoid to retract or to retract the cerebellum and have a bleeding. That's the second point. Then you see the veins. Okay. Third, you look for the arachnoid plane over the dorsal surface of the tumor, and then you dissect this arachnoid. If the tumor is, if you can localize the internal auditory canal, what you do at first is to open the internal auditory canal and then decompress it. If it's not possible, with debulking the tumor, take a look for the facial nerve at first, stimulate the dorsal portion of the capsule, tumor capsule, to be sure that there's no facial nerve dorsal located, and then we debulking it, and then open as early as possible the internal auditory canal, and then remove the capsule from the brainstem and from the nerves.
Thank you very much. That was very interesting. Another thing is about what is your experience with regard to hypervascular vestibular schwannomas, which are by definition supplied by both the external carotid and vertebrobasilar system. These are very solid tumors, younger population. So there is a staged debulking strategy which is followed throughout the world. What is your experience with regard to the hypervascular types of vestibular schwannoma?
Yes, you are right. It's more often in younger patients. You can see in the MRI preoperatively also, you can suppose that there is a hypovascular tumor. What you do is the vascularization of this tumor is coming most from the dura, from this vessel from the dura. Then we attack at first this portion, and then we debulk as fast as possible the tumor to get access to the capsule, tumor capsule, and then remove step by step, and don't try to coagulate very much, just to remove the capsule. And even some patients have more bleeding, but we don't need a transfusion in this case. That's a very useful technique. They don't have problem with these tumors.
Thank you very much, Professor.
Thank you, Professor. Other questions? I see Riccardo Stanzani.
Yes, just a simple question. It's first of all, thank you for this wonderful presentation. It's very interesting for young people that are approaching this kind of pathology, I think. And I want just to ask you about wound problem, healing wound problem for this recurrent surgery. You ever experienced and you never thought to change the straight linear incision that I saw in your PowerPoint? Just a curiosity.
No, that's right. We are always using this red sigmoid approach, and it's hard to work with scar tissue, but we can do it because we don't have any important structure behind the tumor. In the past, I have used the translabyrinthine approach, the middle fossa approach, and the Peters approach for this case. But I realized that with the red sig approach, you can do it very nicely, even if you have a scar tissue after 3, 4, 5 surgeries before.
Okay, thank you.
I have a question about hearing preservation, Professor. So I know some colleagues reporting some patients where the cochlear nerve was preserved, and this patient were complaining of tinnitus after surgery. So I would like to know your experience about this kind of problem in cases where you preserve the cochlear nerve, and your comment about this.
Yes, hearing preservation is really a challenge for us, because hearing preservation is possible, in my experience, in middle-sized and small tumors. If you cut the cochlear nerve, even though the patient could have tinnitus, that's a problem, because the tinnitus is not in the ear, it's in the brain. That's a problem. And if you preserve the cochlear nerve, you can have tinnitus also, but if you cut it, you have the same. The preservation of the cochlear nerve is not a cause of tinnitus. That's the irritation of the cochlear nerve before surgery, and it's like a file in the brain. What you can do for this tinnitus, most of the cases, if you remove the tumor, the tinnitus is going down with months or years, but you can also use the transmagnetic transcranial stimulation in the auditory region in the brain to reduce the tinnitus. That's a problem in some cases, but in the majority of the patients, tinnitus is going down after some weeks, months, or even years.
Thank you, Professor. Very clear. Is there any other question for Professor Ramina? Okay, so thank you very much, Professor, also for answering our many questions. And I would like to ask my co-chair today, Professor Raja, to introduce our second speaker.
Well, thank you, my dear friend Alberto Fallotti and Professor Yoko Kato for coming here and organizing this wonderful webinar. We are extremely thankful to Professor Ricardo Ramina, who gave us such a wonderful lecture. And I'm here to introduce Professor Ramesh Nair. It is an immense honor, and I feel proud to introduce him, as he was my predecessor here in the same college as I am assistant professor now. Today he is cross continents and reached a very high position. We are extremely proud of him. He is currently a consultant skull base and neurovascular neurosurgeon, head of skull base and neurovascular surgery at the Charing Cross Hospital and St. Mary's Hospital, Imperial College Healthcare NHS Trust. He is an integral part of several organizations and of course ACNS, and he has published several articles in various internationally peer-reviewed journals and had won several prizes for and accolades for his contributions towards neurosurgery. Today he is going to talk about AVMs, and I remember in the words of Professor Michael Lawton, who wrote in the 75th anniversary edition of JNS-PG about the future of open cerebrovascular surgery for AVMs and aneurysms. He said that AVMs are freaks of nature, explosions of hemodynamic energy and red fury, with dilated arteries converging from all directions like angry snakes, engorged veins twisting and throbbing from turbulent shunts, and a glistening arachnoid wheel concealing the tangled beast within. So learning to tame this beast is arduous, and he also said that aneurysm surgery is a dance which can be choreographed, but AVM is war. So today Professor Ramesh Nair is going to show us his armory and all the techniques to win this war against this so-called giant beast called AVMs. So over to you, Professor Ramesh Nair.
Thanks, Raja. That was a brilliant introduction and an introduction to the topic as well. And I thank Alberto for inviting me. And of course, Professor Kato is my mentor for 22 years. I think it was almost 20 years ago. I was with Prof. Kato in Fujita. So this invitation gave me an opportunity to reflect, and the nostalgic memories I have from the Fujita. I'll share the screen. So I will today talk about my own experience with some AVMs and the technical nuances, which I think are important when dealing with these cases. And they are beasts of nature, and the AVM surgery is like preparing for a war, and that is a key message one has to understand. As I could show here, Madam was, I was 20 years ago, actually in 2002, I was there for a year, and with the Prof. Kato and Kano, and Prof. Sai Sang from China was visiting us, and they could see me behind was a Sai Sang here. Again, the time at Fujita was quite precious, and obviously opened my views to the world, and imparted a global view. And you could see me here with my good friend Imisu and Prof. Kano outside the intensive care unit, where I spent a lot of time with my colleague and friend Vernon, who was with me at that time 20 years ago. So essentially, when you talk about the RT-AVMs formation, one has to understand that the ruptured AVMs and unruptured AVMs are two different categories. When somebody comes with an acute bleed like this is a young chap who was a high-performing individual, came with a big bleed under the on-call team with a large hematoma. The first intention to save his life. Obviously, the swelling is causing a lot of mass effect, and the clot itself requires evacuation. You could see on the preoperative CT angiogram, there is an AVM pushed to the back of the clot. So as rightly, the on-call team performed a craniotomy to remove the clot, leaving behind the clot over the compressed AVM. So that is the right thing to do in such scenarios. So don't try to attempt to try and resect, especially even if you are a neurovascular surgeon of many experience. So this is something which you need to plan in advance. Obviously, this patient had further swelling, the bone had to be taken out, which means that when they come for your surgical evaluation and surgical intervention later on, you have a bone missing and you have no clear plane to dissect off. And these are situations where the surgery becomes more complex, because your intention is to expose the aneurysm without any risk to the surface or the veins related to it. So one has to be really careful in such scenarios when you don't have a proper arachnoid plane. And also it's important to update the imaging. Whenever you have an AVM, which is immediately after the clot or just around the admission time, you may have to repeat it whenever, if it's after a few months, to make sure that there is no further, because often the clot will mask the true nature of the AVM, and it will compress it, it will obscure some of the veins related to it, some of the vessels related to it. So your job is to understand the RT angio architecture of the aneurysm. So obviously this aneurysm, the AVM, was resected without much trouble. So in terms of the AVM, it is important that you do a complete workup, CT angiogram, MRI scans, and DSA. And all these investigations are complementary. It's not that if you have a CT or MRI, you can avoid DSA or vice versa. You need to look at all these and correlate everything together. Many of the time, I would prefer to operate these patients within their admission time rather than letting it go and come back for a few months later, because when they have a clot, it's often easy to operate them because they will have a pile surface. For example, it's the man who had a temporal lobe bleeding on the left side, and there's a clot, and you can see one of the surface of the AVM will be the hematoma surface, and you have a pile surface, and the only surface you have to dissect is the parenchymal surface. So many of the time when you have a large clot will help you to deal with this AVM. And a few factors we need to look for. Is there any venous stenosis? When you see someone with a possible AVM, you see whether there is any risk factor such as venous stenosis. Are there any evidence of thrombosis? Or is there an idle aneurysm? Any white matter swelling, which you may sort of appreciate in an MRI scan, especially T2-weighted MRI scan. And look at the number of draining veins, and are there any veins draining through the ependyma into the ventricle? Because some of these transependymal draining veins, if they are the primary draining vein, they may have a slightly higher risk because the veins may not be able to take that much of arterial load, unlike some of the cortical veins, because with the time, the cortical veins will mature enough to almost tolerate the higher AV shunting, but not necessarily a transependymal draining vein. So some of these factors you need to really look for to assess the risk of these AVMs to decide when to operate them. So for example, this is a young chap. He was a nurse in a cardiothoracic unit nearby, came with a small area of abnormality on his left temporal area, posterior temporoparietal area. He came with minimal symptoms, some headache and minimal word finding difficulty. The MRI scan, you can see, shows some changes around that suspected AVM. You can see a tiny speck of calcification which points towards possible AVM. So he was referred to my clinic, supposed to attend in a week time, but soon after he came with a bigger bleed. So what was the problem? He came because it was a high-risk AVM. You can see that the angiogram shows supply from the posterior cerebral artery. And but on surgery, you could see that on the surface, you can see these veins are thrombosed. So when the veins are thrombosed, obviously they have a higher risk of bleed. So one has to be very careful with such condition where you see changes in the white matter and the thrombosis on the MRI scan, that they will be high-risk patients who have a bleed. And when you look at the CT angiogram, it's quite useful because especially near the bone and skull base, you know where the vessels are coming to the surface and which are the vessels supplying the AVM and where do they come onto the surface. Because that's where you're going to see when you open up the AVM. And MRA and MR angiogram is quite complementary. You can correlate with both of these modalities to have a clear picture of the vessel supplying it and where they're coming onto the surface. And so your intention when you open up the head and look at the AVM to know which vessel which you have already seen and planned from your CT angiogram and MRI scan to locate it on the brain surface. And for that reason, DSA is the most important investigation, I would say, because you just need to follow each artery and find the feeders coming from the artery. And for this, you need a higher frame rate. You just need to go to the angio room and speak to the radiologist and trying to get as much as information as possible. Because if you have a less number of frames, immediately after the injection, this AVM will fill up because it's a very fast flowing system. So you need to have a very high frame rate to follow this vessel. Often super selective angiogram may be required to identify whether there is en passant vessel, which often there is. And often you don't see a vessel going into the AVM and not coming out, but that's not the case. Only when the AVM is out, you find that the vessel then follows back into the cortex. That is true with all these MCA branches and the antecerebral circulation branches. So unless otherwise proved, you have to take each vessel as an en passant vessel when you operate on these patients. So it is important to confirm the anatomy around the AVM, especially with the DSA, and also look for the venous system, because veins can lead you towards AVM, especially deeper AVMs like a sulcal AVMs and intraparenchymal AVMs. You have to locate the AVM in the first instance. The navigation is useful, but also the veins are the landmark. They will be on the surface. And you need to look at which is the primary draining veins and the secondary draining veins, because at some point during an AVM resection, you may have to sacrifice some of the veins, because then you have to decide which one to sacrifice first. Then you need to know which is the primary draining vein. For example, in this case, so late arterial phase, you see these veins, and there are veins draining anteriorly to Sylvian fissure. This is the temporal AVM, but there's a main vein draining into the sigmoid-transversinous junction, but there is a stenosis associated with it. But both are almost like an equally dominant venous system. And look for any associated nodal aneurysms or perinodal aneurysms or even proximal feeder aneurysm. These are things which we need to look for. Sometimes when you operate an AVM, you find that this arterial feeder directly becoming a venous sac. It's like a direct fistula of the within the AVM. One other thing which is important is when you open the dura, make sure that you open in such a way that none of the veins are disturbed. Doesn't matter what sort of flap you make. There's no need to have a beautiful flap to one side like we do for all the operation. In AVM surgery, the priority is the vein. So you may have to tear it, you may have to cut whatever fashion you have to, just to avoid preventing damage to any veins. And also during the procedure, especially putting retractors on something, make sure that you're not compressing or kinking the vein. So this is a temporal AVM here. It's a man in his 60s who came a while ago. This is the temporal lobe here. This is the left temporal lobe. You can see I can follow this artery and the arterial pattern, then identify the same structure on the surface of the brain. This is, I know, primarily going into the AVM, but this branch, I'm not certain. So I may have to follow it deeper to see whether it is participating in the AVM or whether this is going somewhere else. Often these vessels will go somewhere else. Look at the dissection. You've got to be careful with the bipolaring of this vessel supplying the AVM from the parenchyma. You have to maybe include a bit of tissue around the AVM to coagulate it fully. This is what Prof. Hennis-Mamie often used to mention about dirty coagulation. But the most important thing which I have to remind you is the bipolars used. You have to use the appropriate bipolars. Don't use bipolars which are very big or very small, and also use the appropriate current. When you use a very tiny, like a 0.5 millimeter tip of bipolar, you have to reduce your bipolar current accordingly. Because if you use higher current, instead of coagulating the vessel, it will just cut the vessel and it will bleed. And in situations like AVM, bleeding into the surface, bleeding into the parenchyma, it will retract back and you won't get it back. And that is the common cause of postoperative hemorrhage or postoperative clot for after AVM resection. Here I know that in this case, there is a clot deeper to it. So I dissecting around the medial aspect of the AVM, get into the clot. Then once you get into the clot, you know that most of the surface is dissected, and then you complete the resection. I just fast forward it. That's the vein. I'm just keeping it towards the last, and then go around the base. So this is the temporal base. I don't have to remove any veins you see there because there are veins which are not participating in the AVM. So just go, the dissection is circumferential or as much as possible. So once you disconnect all the arterial feeders, then essentially it's a matter of disconnecting the whole AVM and disconnecting the vein at the end. And this is the bipolaring I'm talking about. You just need to make sure that you have enough length. Don't try to coagulate on the brain. Leave some length for you to make sure that you have sufficient length to control it, even if it bleeds again. In some cases, one may have to use clips. Most often, larger veins and larger arteries may need clipping. And there are clips for AVMs, which are sometimes useful, but especially when you want to use a lot of clips, AVM clips may be better, but you have to be careful that they have sufficient closing pressure. And that closing pressure you can only ascertain or confirm with the aneurysm clips in many, because the AVM vessels are quite small and they may not be strong enough to hold it. This is a young lady, a nurse by profession from a neighboring trust, came with an acute bleed and significant dysphagia on the left frontal lobe, quite closest to the Broca's area. And the problem with some of the patients like this is that they have feeding arteries from the major MCA branches, but you will be operating on this MCA and you'll be finding all the feeders and disconnecting it. But you can see it's a conical shaped AVM, which is often the case, and they will be pointing towards the ventricle, but one has to ascertain the kind of feeding they have. So here you can see that there is a very deeper branch as a deep feeder, which you're not exposed, which you're not going to expose when you expose the AVM. So these feeders you have to make a judgment call at the time of the operation, whether to take it, because you will be traversing the white matter, coronal radiator. In this location, I did not. I left that part because there was a draining vein which is draining it. And so that was left at that time. Normally, when you see a remnant AVM in the postoperative angio, the indication will be to go back in and remove it if you know where it is. But in situation where you leave it intentionally in this case, this is when you need to consider adjunctive treatment, such as in this case, she was given Kamana for the small remnant. So traversing this white parenchyma will be risky in such situations. So you've got to think about the adjunctive treatment in some cases, even though this is not a common scenario, but it is something which you need to keep in mind. So for example, this guy, he's in his 60s, came in 2019 with a bleed, small bleed. You can see a small bleed around the right temporal lobe from a vein of labor thrombosis. But on further scan, we could see that his brain was really congested with a big AVM frontally, and a lot of venous congestion around the brain because he had sinus thrombosis. You can see the AVM is here, and he had a previous stroke in the temporal lobe from his venous labor thrombosis. But generally, his AVM was quite complex, supplied by most of the anterior cerebral arteries, and also some of the other branches which normally do not give branches to the AVM, because you see the ophthalmic artery supplying the FOX to that model, and then it goes in to supply the AVM. So sometimes it can be quite difficult. In this case, you can see the rest of the sagittal sinus is blocked. That's why the brain was congested and not helped by having a big AVM in the frontal lobe, because that increases the circulation. Also, he had an aneurysm lower down. This is a lateral view of the antecerebral circulation. You can see a small conical aneurysm here and a big AVM frontally. So in such a situation, there are limited options and high-risk operation when you know that there's a high risk of having complication from the surgical. So while waiting, he came back with a bleed within few months' time with the suprachiasmatic hemorrhage. So I wasn't sure whether he bled from the AVM or from the aneurysm. But anyway, there was no other choice than to consider resection of the AVM. And in these cases, adjunctive treatment is quite full. I don't tend to embolize all the AVMs, but in some AVMs I do embolize. That will help you, especially with the high flow AVM. Some of the feeders, they can be taken out, will help with the surgical intervention. AVM embolization is not always complete, and most patients will have a remnant. And even if you don't find any major remnant immediately post-embolization in some AVM, you may have to consider repeating the angio few months later to make sure there's no further recurrence, and maybe even a delayed angioelectron. But some of the AVMs are really help to have a preoperative embolization. You can see this some of the feeders. In this case, you look at the external supply. The middle medial artery is supplying the this AVM coming from the FOX and then goes into the AVM. So when we study this angiogram, you need to know where the feed is at. You have to number them. You need to know where you have to get them. So once you have that plan in your mind, the surgery is almost easy. So for example, in this case, use that the FOX branch. This is the interhemispheric approach for that AVM. This is a FOX. This is the midline sinus here. So I have, first thing is to look for that branch coming from the FOX, supplying the AVM. So that is isolated first. Then it is ligated. Then you go for look for other feeders in artery. And so when you find the feeding branches, you need to follow this and then find out which are the feeding arteries that goes into the AVM. But not all vessels go into the AVM. And sometimes you have one side of the normal branch going to the AVM, the feeders, but the other side of the branch, other side of the artery will give feeders to the normal parenchyma. So this is a large complex AVM. One of the things which you can see here, this is the midline here, and this is the right frontal lobe. And you can see a cortical vein overlying it. So it is not completely AVM draining vein, because there is a normal cortical venous supply going through this AVM. Some of the AVM veins are draining into it. So it's important to preserve it. These are some of the embolized branches you can see here. So I'm separating the AVM from the cortical veins. I know that some of the AVM veins are joining it. So it's important to make sure that you don't take off that vein. You can see some of the feeders are taken off by the embolization. And the resection will carry on until you finally disconnect this big AVM vein at the end. We'll need a clip to occlude it. But you have to remember that patient with the large AVM also had a proximal aneurysm around the ACOM region. So AVM was higher up in the midline. Normally for ACOM aneurysm, you have TDNL approach, you have interhemispheric approach from the front. But because we have already done the AVM resection here, and also I wasn't sure which aneurysm, whether he bled from the aneurysm or from the AVM, I had to deal with it. So through the same approach, I could approach the aneurysm from the top. It's like a superior interhemispheric approach. After resecting the gyrus rectus from the top, I could get to the AVM. But the only problem is that you will be coming to the fundus of the aneurysm. So one has to be really careful whether it's a ruptured or unruptured. In this case, it was unruptured, and so it was clipped along with the same time of the AVM resection. And some of the posterior fossa aneurysms also technically have to strategize in terms of they may have hybrid supply, not only from the parenchymal vessels, also from the meningeal vessel, especially from the posterior meningeal artery coming from the occipital or the pica. They may supply the AVM, especially near the tocula. You find hybrid AVMs. And you find the superior cerebral arteries coming over the surface, which you can get to, and the pica you can get to from the back. This is an example case where you see the pica branches coming and supplying it. And you have the ICA branch, also the superior cerebellar branch coming anterior to the AVM. These branches sometimes are difficult to reach at the time of the resection. They may be useful to get some embolization of the front branches. This is where your interventional colleague can help you. So this is an embolized branch, and then once you resect it, you can resect it without much difficulty. So head position, elevated. Keep the AVM on the surface. You don't want any venous turgidity, venous tension when you're exposed to aneurysms. You want the venous pressure to be low. It's important that you keep it that way to avoid venous pressure around the, especially the veins around the AVM, because you want to coagulate them and not having any venous hemorrhage. So unruptured aneurysm, I remember, and I was in Fujita, Prof. Kano said to me, the two surgeries where surgeons are really stressed about. One is the MVD, and the other one is unruptured aneurysms. The reason is that they are essentially normal patients. They don't have any other major problems or tumors or anything like that. You're operating essentially on normal patients, so that's why you are stressed. I would also say that unruptured AVM, because they are similar to unruptured aneurysm, because they are otherwise well apart from having this AVM. This is a young chap, came to see me with an unruptured AVM from the frontal region on the left side, but he didn't. This is a primary vein and the secondary draining vein, but he didn't want any scar through his hair follicles, which were very precious for him. So the only option was to do an incision right over the forehead, and then the primary principle is that you need to have a wide exposure of the EM. So even if you are compromising on your the incision, you have to make sure that you have adequate exposure of AVM. What about craniotomy? Generally, as I mentioned, a larger craniotomy. You got to see every arteries and vein. You have to see what you can identify on the scans and the angiogram, and then go ahead with the surgical planning. This is what I think Raja also mentioned before, that it is like a war. You just need to study everything about the enemy. The more you know about the enemy, the more chances of success. And venous pattern has to study. You need to understand where the vein is draining. Sometimes it can be difficult to understand whether it's a vein or artery, because they exactly look like arteries. Only your angiograms and the pattern of their anatomy will help you to identify whether it's an artery. Or sometimes you can sequentially clip the vein to see where the flow is going towards the AVM or away from it. And often when you identify the feeders and then clip them, temporarily you can see the change in the venous flow, which also will help you to identify it. So I'll take one example to give you a perspective of the planning of this AVM. The lady who came with a bleed in the right frontal lobe, with a hematoma of the right frontal lobe. And here, when you study the angiogram, you can see there are two branches coming from the front. One is here, the anterior cerebral artery branch. Other one is a branch of the anterior, pericallosal artery, which then comes and in the midline. This is interhemispheric area. This AVM is mostly surfacing on the interhemispheric area, but then it comes in the interhemispheric fissure, then divides into a posterior branch and anterior branch. The anterior branch directly goes to supply the AVM. The posterior branch, then a portion of it comes back and supply the AVM. So you know this branch is there, this branch is there, this branch is there. There's another branch here. So these are the things which you need. So at least four feeders. And once you have got control of the 4 feeders, then you know that you will have no problem in dealing with it. So in this case, the AP view will tell you more clearly. This branch is connected to the AVM, which you will identify on the surface. This branch is in the interhemispheric feature. So what you need to identify is this branch, see whether you can identify this pattern, and there will be branch which is more medially as well. The venous pattern, note the primary vein and the secondary vein. So here, see, look at the dural cut. Don't worry about what sort of flap you have. Just cut the dura wherever, as long as you don't damage the vein. So this vein is a normal cortical vein. This vein is almost like a red arterial vein, but you can see here the cortical blood is mixing with the arterial blood here. So this vein is also being contributed by some of the AVM veins. So it's important that you preserve this vein because cortical vein is also coming through it. So this is if you look at the MRI scan, this is the pattern I showed you. Here you want to identify this branch coming to supply the AVM. You know that one branch is going to supply the AVM, and this is the pattern you have. Exactly, this branch goes directly into the AVM. The other one goes back, and that goes to supply the normal cortex. But again, I have to follow it from behind. So this is a posterior part of the right frontal lobe. Midline is over here. So I'm just exposing that branch that comes back. So I need to identify the depth of the sulcus and then temporarily clip it. So then it's temporarily clipped. Then I'll go on to clip the other branch in the midline. And then I'll also clip the other branch, which is coming more anteriorly over here. You can see that branch is divided. And then I go around the AVM. So this is the AVM being resected. You can see that the vein is left for last, and finally you divide the draining vein at the end. And the most important thing, apart from the circumferential dissection, is the way you manage the vessels surrounding the AVM. So she had a clot which was useful. This is the postoperative scan. So similar lady, similar case with an AVM on the left frontal lobe, but reaching the ventricle there. And these are the kind of scans you need to look at, because you can see there is a cluster of vessels from both arteries, and you have to find out where are there any feeders coming more proximally, because you'll be exposing these branches, and you want to see whether there is any branch coming from more proximally. So these are the things you need to clearly look for. So this sort of early arterial phase will help you to see, because all these vessels are abnormal vessels. You can see them on during the operation. And sometimes you can see small aneurysms on the vessel as well. So in this case, this was not showing any further en passant vessels. After that, this was embolized. Then subsequently, I disconnected the other branch. So another case, here in this case, one can see that there are branches coming from one of the pericallosal artery, but also from a more distal branch. But the problem is, are there any other parts of the AVM which are more peripheral? Because if you remove this AVM by just following the artery, then you will miss this part of it. So it's important to know whether there is a feeding artery from this one supplying the peripheral part of the AVM. Here you can see the dura is being cut, and this is the interhemispheric part of it. This vessel here, you can see it's got this is a feeding branch. The AVM is under this patty here, but this artery is abnormal. It's almost like an aneurysm with a kink in it. So this artery, it was an en passant vessel, but there are feeders going into the AVM. So this aneurysm needs to be dealt with at the same time. So we'll need to reconstruct the artery, excluding the AVM. We'll fast forward it. So this is an interesting case, a young lady who came with an acute bleed. You can see that there's a big AVM of the right occipital area. But the important thing is that she also had a small aneurysm, juxtanodal aneurysm, which is chest peripheral, because you can see there is a small aneurysm. And sometimes when you follow this patient within a few days' time, you can see these aneurysms get bigger. In this case, the 2 MRI scans in a few days' time showed that the aneurysm was getting bigger. The AVM is surgically accessible, but you have this radiation, optic radiation, just between yourself and the aneurysm. So in this case, it will be useful to get an angiographic image to embolize that aneurysm here. So you can see that's a big aneurysm, which is separated by a white matter fiber tract. So you can, once you resect the AVM, it may be a bit tricky to go for the AVM surgical. So it's useful to embolize it prior hand. So once it's embolized, this is what you see. You see, so you can see that this is the right parieto-occipital area. This is the posterior aspect of it. And this arterial pattern is what I was talking about. If you look at this branch here, the MCA feeder, look at the shape of it. This is what you identify on the surface. This will help you to give you some clarity about the angio architecture and then confirm your anatomical planning. So the bipolaring of the AVM around it had to be very careful, and having an appropriate bipolar and correct current setting is invaluable. So finally, I'll stop by saying that what you need to do is to study the angiographic anatomy in detail. You may have to sit down with your interventional radiologist and go through it. If you need to have a super select, you may have to have it surgically, because you get one shot at it. At every step of your operation, one has to be in control. It's not like some of the tumor surgery. You can just carry on operating when there is bleeding going on. You just need to be on top of the AVM. So if you are on top of the AVM, you will be in control. Otherwise, I find that at one point in the beginning, you are doing perfectly well, and then things can go very wrong, because once you start bleeding, sometimes you can do very risky maneuvers to try and control it, just like when you have intraoperative aneurysm rupture. But here the problem is the blood will go into the parenchyma and have a big hematoma, and the bleeding can be uncontrollable. And be careful about the vein, and look at the venous pattern and plan for each arterial feeder. Finally, your interventional colleagues can help you in many cases, and always do a post-operative angiogram to make sure that the AVM is completely gone, and be willing to take these patients back to theater. And selected cases, you may have to consider stereotactic radiosurgery. Thank you. This is a welcome party for my family when they visited me for a month. I'm standing behind Professor Cano here. My wife is behind it. And Madam is holding my son, who is now a 25-year-old man, is a doctor now. So time has flown. Thank you very much. I will stop sharing, and thanks again.
Well, thank you very much, Professor Ramesh Nair, sir. It was an excellent demonstration of the technical nuances of the so-called natures of BIST. So we'll open the forum for discussion. Let me start with me. I would like to ask that emergency surgery of AVMs is like, okay, but when you perform an elective surgery for AVMs, what is the pre-operative preparations that you give for the patient, and what is the post-operative follow, immediate post-op ICU? What do you think? What are the things you look for?
Yeah, thanks, Raja, for that. That's important to have, especially for an unruptured AVM. I think the talk, whether the discussion about whether to offer treatment and what sort of risk you quote to the patient, that's a separate discussion. But in terms of preparing for this patient, all these investigations, including the CT scan and CT angiogram and an MRI scan, as well as the DSA, they're all complementary. You need to look at each of these investigations. And also in some cases, when you are operating near some eloquent structures, you may have to understand where the functioning areas is, which tract is going nearby. You may have to do additional investigations to look at those sort of factors. And in terms of post-operative care, all these patients ideally should be treated in intensive care unit where they can monitor intra-arterial blood pressure. So my policy is to keep the blood pressure between 90 and 100, at least for the first 24 hours, and then relax it within the next few days' time. So it's unlike an aneurysm surgery where you may want to have a slightly better blood pressure. In this case, you want the patient to be sitting up a little bit and also having a low blood pressure. What you want to do is to avoid venous congestion. Sometimes when these vessels, which are abnormal vessels, which you have coagulated, sometimes they can open up in the postoperative period, especially with the venous congestion, and then can have hemorrhage. So the instruction will be to keep this patient in a slightly elevated position, and also with a lower than. It's not a 90 to 100. It's not absolute. It's always related to their normal pressure. Somebody who is hypertensive, who may not want to lower that much. So if they are hypertensive, their blood pressure lowered than whatever their normal pressure is. So it's not like you always, for every patient, you go for 90 to 100.
Thank you very much. We can take comments from Madam Professor Carter.
Thank you very much. Thank you very much for nice photographs 20 years back.
No, when I was showing your picture on the screen to my wife, and she was saying that you look the same. So
thank you so much. So you focus on the venous structure so many. So how do you think about the venous embolization through venous system? Embolization, how do you think about it?
Yeah, so I think the transvenous embolization for AVM is not performed in all the centers. It is not a practice in our center. I haven't seen many aneurysms being embolized transvenously, but I guess it is an option in some cases where you have access to the arterial side of the AVM through the venous system, because what you don't want is to have put a glue or embolizing agent and then to have occlude that venous system, because that will be a disaster. Many of the complications from preoperative embolization, especially in deep lesions, happens when they get the reflex, embolizing material reflexing back into their original parent system. And so in selected cases where you have access to some of the parts of the AVM through transvenously, I think it is a good technique. I know that many centers do it, but not in our center.
Thank you very much. Thank you. Thanks so much. Still in Japan, it's not so many centers can perform the venous embolization. Thank you so much.
Thank you very much, ma'am. We can go to Professor Ricardo Ramina to hear his comments.
So thank you very much, Neri, for this very nice presentation for this technique. I have two questions. The first one is, do you think it's useful to use ICG or glow technique for AVM surgery? And the second question is, in the 80s, Spätzle described the normal pressure breakthrough syndrome. Have you seen some case with this syndrome?
Yeah, I mean, even when I was training before, we used to talk about this normal perfusion pressure breakthrough all the time, and theorize about all this complication from large AVM resection, especially aneurysms, which are quite big. Always we talk about and worried about normal perfusion pressure breakthrough, but not that much these days. We don't really. I think the main thing is that you often also try to control this AVM, especially the larger ones, with some adjunctive technique, including partial embolization, and then that will reduce that kind of reversal or change of hemodynamic the situation in a gradual manner, rather than all of a sudden following a big operation. So, but I think there is a risk of such a complication with the sudden occlusion of big arterial system and sort of changing the flow to normal structures, especially when there is already an established T phenomenon around the AVM, and then more commonly, if you do have some problems with the venous system during the operation, and especially with the uncontrolled bleeders from the parenchyma. So it is a problem, but not so much as we used to think about in the past. Regarding the first question about the ICG, as you know, ICG has got slightly limited capacity compared to an aneurysm surgery, because in ICG, you will see what you expose. Your intention is to look for any remnant. If you're not seeing the remnant, because it is hidden by some cerebral tissue, you will not see with the cerebral ICG angiogram as well. But it will be useful in the beginning to look at the some of the AVMs to see the way the artery is filling up and how the veins are draining. Even though most of the time you see all of them filling together, but in many occasions you can also see the difference in terms of their flow, especially use the algorithm with the FLI 800. So I think there is some usefulness with the ICG, but I wouldn't depend on it to exclude residual AVM. If
there are any further questions, Dr. Libun Singh? Yes, Alberto.
Yes, thank you very much, Professor Ramesh Nair, for this wonderful lecture. I have a question about the stress aneurysm. You have shown a case of an aneurysm in the anterior complex, which was quite close to a ruptured AVM, and you clipped the aneurysm in the same procedure. There are some cases where we see an AVM, but the aneurysm is far away from the AVM itself. So in elective cases, what's the correct strategy in your opinion? Yeah. Is it to focus first on the AVM and look and see what happens with the aneurysm, or clip the aneurysm first?
Good question, Alberto. In that case, that man came with a bleed, and the AVM was not the aneurysm was not near the AVM. It was quite distal and far, and it's more proximal. But because I wasn't sure which was the offending or culprit regarding the bleed, I wanted to make sure that there's no ruptured aneurysm with it. That's the only reason why I clipped that one. So, but in cases where you have an unruptured AVM with a proximal feeder aneurysm, the strategy should always be remove the AVM, and then often these proximal feeder aneurysm will settle down in future without any surgical intervention. So that's the policy I follow. But unless in some cases where you think there may be a risk of, especially with the angiographic images, if you find that there is a high risk, even if you had resected AVM, if you find that there is thinning of the vessels or multiple lobulation, and the time for the aneurysms to settle down will be quite long, and so you can't take the risk, you may want to consider a separate sitting unless the aneurysm is close to your AVM.
Thank you very much.
Thank you very much. Yes, Libun Singh, any questions?
Thanks, Raja. Prof, I have two questions to ask you, Prof. You think which type of aneurysm is easily ruptured? Small, large, and partially embolized, these three groups. Another question, Professor, what is the best embolic material to be used to downsize or downstage the AVM before surgery, either onyx, histoacrylic, or a coil? Thank you, Prof.
Yeah, thanks, Liu. I think good questions. The question about the AVMs, the big or large, are you talking about the aneurysms or AVMs with the
AVM, large, big, and partially embolized?
Yeah, so the risk of rupture, it depends often when you have larger AVMs. You know, if once you embolize it partially, if the venous system is not taken care of, there is a risk that those patients can have a bleed after the embolization. So generally, the indication to embolize these patients depends on the kind of angioarchitecture they have. If you find that there are areas where you can safely take out the feeder artery, and those are difficult to take out surgically, then those are the cases you may want to embolize, so that you can have a much better control of the whole AVM. If you have an AVM which find that I should have shown another case, if you find that they can embolize it, but this is also something which you can treat surgically without going for the embolization, it maybe I would try to avoid embolizing, because embolization always has a small risk attached to it. The angiogram itself and also the act of embolizing it would always carry about 2 to 3% risk of having a complication from the procedure itself. And on top of that, you're operating on those AVMs, and which will have another maybe 4 or 5% risk of having a major complication. So you don't want to add up all these complications. So if you find that you can access the feeding artery surgically itself, even if they are accessible endovascularly, embolizable, I would not embolize them, because it makes surgery much more easier if you have a direct virgin field where you can access the feeder artery without having embolizing material and scarring and arachnoid additions around it. And your second question was about, just remind me what you were asking.
Embolic material to be used.
Yeah, so embolic material, we in the UK generally tend to use a number of agents. And you see or know this case where you see some white stuff in the artery, which is a fill, they call it. It's a kind of acrylic material. But also you could see some of the bigger arteries will take coils, because it's easy to take off that vessel itself. And it's more safer from an endovascular perspective to use coils, especially with big arteries. So it's often a mixture of things. And often onyx and other gluing agent, they have, especially for deeper AVMs and tiny arteries, and distal MCA arteries, where they have to go quite long way in as a risk of this complication where the catheter gets stuck in with the glue. And before they could retract it, the whole thing solidifies it. And the only way in that those sort of cases is to cut the catheter of the groin. So there were a few cases where we had to leave the catheter in the patient, but normally it doesn't cause any problem at all. They get endothelialized and they don't need to have long-term anticoagulation, but it is a complication which we have to be aware of, leaving catheters in.
And thank you, Prof.
Thank you very much. If there are no more questions, I think we can wind this session up, and I will hand it over back to our host, Dr. Alberto Felitti.
Thank you, Raja. Thank you so much for helping me chairing this session. I would like to thank both our speakers, Professor Riccardo Ramina and Professor Ramesh Nair. I would like to ask Professor Yoko Kato for some final remarks.
Thank you so much. So the two speakers, the topics are very excellent. Especially Ramina has a huge experience of the skull base, especially the giant vestibular schwannoma. So maybe I think recently radiosurgery is coming up more and more. I think that we should preserve the mobility of the patient. I think it's a good idea to introduce the radiosurgery. But anyway, that your great experiences so fantastic. Thank you so much. Ramesh, thank you so much. And the AVM itself is not so many cases, so maybe you can share for the young doctors the strategy or what is a good indication, and also the intraoperative images, many things, especially the elegant lesions, and also the grade 4-5. I think it's the future from I think. Anyway, thank you very much. So I will see you next time.
Sure. So thank you very much to our speakers. Thank you to all of you who joined. Thank you, Raja, and you for helping with the organization. Thank you, Professor Yoko Kato. Thank you, Riccardo Stanzani, for joining. And I will see you next month for a new Alumni Association webinar.